Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Genentech.
Hello, I'm Dr. Joshua Sabari, Assistant Professor of Medicine and a thoracic medical oncologist at NYU Langone Health Perlmutter Cancer Center here in New York. Welcome to the program titled Best Practices for the Multidisciplinary Care of Patients with Early-Stage ALK-Positive Non-Small Cell Lung Cancer. Joining me today is the one and only Dr. Brendan Stiles, who is the Professor and Chief of Thoracic Surgery and Surgical Oncology at the Albert Einstein College of Medicine and Montefiore Health System here in New York. Welcome, Brandon.
Hey, it's great to be here, Josh. Great to be here with such a leading authority on these topics as you.
And please go easy on me today. So for the next 15 minutes, we're going to do a rapid-fire program. We'll have 90 seconds to address a specific topic focusing on the multidisciplinary care for patients with early-stage ALK-positive non-small cell lung cancer. All right, Brendan, let's get started. Let's jump right in. Let's get 90 seconds up on the clock. First, tell me about a typical patient journey from initial presentation with early-stage lung cancer.
Yeah, great question. I'm sure it's a little bit different everywhere. Probably even at each institution, each patient's journey may be slightly different. We like it for the patient to get to see the surgeon first, along with our interventional pulmonary team, and we sit side by side in the clinic. I think that gives us the best chance to talk through about what the best strategy is for diagnosis and staging up front.
Yeah, couldn't agree more. Having a multidisciplinary team here is critical. So you're seeing your patients with medical oncology, with radiation oncology. How does that work?
Yeah, great question. I'm not opposed to them seeing them first, and sometimes that's just a pathway of care. But we often find that they want to send them right back to us to do the diagnostic procedures and the staging procedures. And so when we can, we've tried to make that the doorway. But obviously, they come through lots of different avenues. The medical oncologists and radiation oncologists are right there with us in the clinic, too.
Yeah, very complex pattern for referrals. What are you doing? What staging modalities are you doing up front?
Almost all of our patients are getting navigational bronchoscopy and EBUS at the same time. Over 75%, I think, of our even early-stage lung cancer patients. We're trying to look at those nodes up front to trying to understand, look for occult nodal disease and understand which patients might be candidates for neoadjuvant therapy versus which ones we're going to take the operating room first and go down that adjuvant pathway potentially like we're going to talk about here.
Yeah, and how do you feel as a surgeon referring to us lowly medical oncologists? Any trouble getting in?
No, well, I tell you, the medical oncologists always like to have them all buttoned up with the stage and the diagnosis and everything done. We're kind of the working horse group. We're just the boots on the ground. But we like that part. We like to sort of talk to the patients from the beginning, really explain the journey. If you think about that puts the pressure on us to really know the adjuvant data, to really know the neoadjuvant space, and to not just sound like a bunch of dummies when we're talking to them, but to elaborate on all these things about biomarker testing, about the journey, about when they might need adjuvant therapy. So a lot of more pressure on the surgeons to be involved in the multidisciplinary team. I think we can't just keep operating with their heads in the sand.
Yeah, couldn't agree more. Went over there a little bit, but let's keep it going. So, Dr. Stiles, what's the role for the oncologist versus the surgeon? Let's get another 90 seconds up on the clock here. What's the role of each specialty in this space? I mean, what do you do versus what do I do?
Yeah, I mean, I think really the surgeon is the most important in the adjuvant space. And I hope the medical oncologist will disagree with me about that, right? But I think we have to set the journey. First, we got to get them to the OR. We got to do a good oncologic operation. We got to stage the lymph nodes to identify patients eligible for adjuvant therapy. But we also got to set them up for the concept that surgery might not be all that they need, right? That there might be nodal disease that we find in the operating room that they might have to go talk to the medical oncologist. I think that the more that we can do to kind of set the stage for the really smart medical oncologist to come in with the really fancy drugs really helps patients to get there. If you think about it, we also got to get them back safely. That means doing a good operation with low complications, get them to return to sort of their best quality so they can be in good shape for you guys.
Brendan, aren't most patients with early stage disease, primarily stage 1, aren't they cured with surgery alone? What's the role for all this additional testing?
Oh, man, I was so sad when I saw some of the sublobar resection versus lobectomy data on the earliest of the early patients. We found we weren't curing them. About 30% of patients were recurring. And so, then when you think about stage 2, stage 3, obviously they need more therapy with you guys, with medical oncologists and biomarker-directed therapy. So we got to do this, and we got to really lay it out for the patients.
Yeah, couldn't agree more. Getting PD-L1 expression up front, both, EGFR and ALK testing by NGS, critical. And I would even argue we should be doing broad panel NGS because there are so many just neoadjuvant as well as adjuvant targeted therapy opportunities in this patient population.
Totally agree. Yeah. Hey, Josh, we're going to talk a little bit about biomarker testing, but help us figure out when we should do that. Does it need to be just after we take the tumor out, or should we be doing it up front as we start to see neoadjuvant options even for targeted therapy?
Good, a great question. We have neoadjuvant and perioperative immunotherapy regimens that are FDA approved with survival benefits. But interestingly, driver mutant patients were excluded. So I would argue, and I really hope you agree with me as a thoracic surgeon here, that we need to do testing up front before resection. Yes, no?
Yeah, I totally agree. I mean, the question is always how nuts should we be like if we can't get it, or if you get that and not enough sample, do we need to go back and do it?
Yeah, completely agree. And then post-resection, there's a lot of data for both the EGFR and ALK space for adjuvant therapy, particularly in the EGFR space, improving overall survival, the ADORA trial, which we'll talk briefly about, as well as more recently, the ALINA trial in the ALK rearranged patients. So, you're a thoracic surgeon. Tell me a little about the ADORA study.
Yeah, and it's been the bedrock of things, right? Really, I think changed the way we think about targeted therapy in the early stage space. Obviously, a huge difference first in disease-free survival, favoring patients who got osimertinib in the adjuvant setting. And then second, we saw an overall survival benefit too. I think that resonates with patients. It resonates with surgeons, this idea that they're going to have a biomarker that the surgeon can send the oncologist to treat to. And it's a little bit different from ALINA. I mentioned to hear your thoughts as we talk about, most patients got chemotherapy first, particularly the higher stage patients, before going on to osimertinib. And whether ALINA changes the paradigm on that, we'll see.
Yeah, excellent point. I still, stage 2, stage 3 patients, give them adjuvant chemotherapy followed by adjuvant osimertinib per the ADORA regimen. Great discussion on this.
All right, Josh, but let me ask you, right? So we saw ADORA and we got all excited about it, right? And then ALINA, sort of, I think we all expected the same results, but it's a little bit different, right? And so, surgeons, we're not as sophisticated with trial design, but tell us how this is different trial than ADORA.
So the ADORA trial was, adjuvant osimertinib post chemotherapy. So patients were resected, had chemotherapy, 75% of them, and then were randomized to osimertinib versus control. Here in the ALINA trial is a little bit different. We looked at ALK rearranged patients. Patients were all resected with early stage disease, stage 1 to 3A. And post-resection, we did not look at patients getting chemotherapy. That was an interesting sort of nuance in the trial. And curious to hear your thoughts in a moment. Patients were randomized 1-to-1 to alectinib versus control. And what was extremely impressive was a significant improvement in disease-free survival, both in, all-comer stage 2 to 3A, as well as the intention to treat population. And what I found particularly interesting, because as a medical oncologist, we need to look outside the chest, we're commonly monitoring these patients for CNS disease. The rate of CNS disease-free survival was significantly improved at 24 months, 98+% for alectinib versus about 85.8% for chemotherapy. And those look to be sustained going out, past 4 to 5 years. So your quick thoughts on the ALINA trial?
Well, I felt a little targeted when you mentioned looking outside the chest. I felt like that was a targeted comment, but I think it's a game changer, right? And
we're talking about targeted therapy.
It further reinforces the paradigm of targeted therapy for these patients. Absolutely.
Great discussion. All right, let's jump into the next topic. Let's get 90 seconds up on the clock. So what is the role of tumor boards in early stage ALK rearranged non-small cell lung cancer? And do you let your medical oncologist speak at your tumor board?
Well, fortunately, our medical oncologist runs the tumor board, and I'm too impatient to run it, so I think that's good. But I think, in most surgeries, that's probably true. It's become more critical. And, it used to be we'd only talk about the really complex stage 3 patients, but now we're talking about all the, the high-risk stage 1, even stage 1s, as well as the stage 2s and 3s for exactly this reason. And we're talking about them really at diagnosis. Should they go the neoadjuvant route? Should we wait? And should we pull, think about really this is an adjuvant type patient that really is critically dependent upon the staging, obviously. How about you? Do your surgeons go to the tumor board? You guys integrate with everybody? How does it work there?
Yes, our surgeons are leading our tumor board, unfortunately, right? Because I think the medical oncologists have a lot more important things to say. But it is interesting over the last, I would say, 3 to 5 years, we have seen more of the molecular discussion happening in the early stage setting. When I started in practice, Brendan, a 2-centimeter nodule, that was resected up front with no discussion at all of really staging or molecular testing. Are you doing molecular testing? Yes, no. What needs to be done in the early stage setting?
Yeah, we are unfortunately have reflex tests in all of our biopsies, and we're getting NGS. You could argue whether you should do a more focused panel. I think that's a discussion for a longer period of time. But I think we have to at least take a shot at something, even at the first biopsy spot. What do you think?
Couldn't agree more. I think EGFR and ALK is critical to guide therapy that is FDA approved, improving outcomes for patients with early stage disease. All right, let's get another 90 seconds up on the clock here. So, Dr. Stiles, tell me about some of the challenges and barriers. It's not all rainbows and unicorns. What are some of the problems with doing NGS up front?
Yeah, I mean, it's tough. You got to get enough tissue. So you got to think about whoever the biopsy person is, right? So they have to be integrated into the multidisciplinary team. And then you got to hit it. I really think that navigational bronchoscopy and some of the new tools we have has overcome a lot of the old challenge with bronchoscopic based. We tend to get more tissue when we go endobronchially, and as well as staging of the node. So I think really important. Obviously, pathology has to buy into. We really haven't focused on pathology, but you got to get buy-in there. I think reflex takes a lot out of the question, out of the story rather. Where you don't have reflex, it becomes harder because you got to think: could this be lung cancer? Do I have to ask for it? What stage do I think it is? All that stuff, and so a lot of things to juggle there. And it probably just depends on your local strengths and your local sort of algorithms, right?
Yeah, I agree with you. I mean, surgeons are good at one thing, getting tissue, but how do we get the NGS before going to surgery? And you hit it right on the head. I think interventional pulmonology as well as interventional radiology, particularly with interventional pulm and the navigational bronchoscopies, we're getting lower and lower false sort of negative or non-diagnostic biopsies. And critical, again, to know the molecular results before taking the patient in the operation, because that may change the outcome for that patient.
Yeah, I couldn't agree more.
Look at that, coming right in below 90 seconds. Let's get this moving. So, Brendan, your thoughts on the neoadjuvant space, particularly with the LCMC leader trial. This is a neoadjuvant screening trial where we're just trying to understand what is the rate of driver mutations in the early stage patient. What are your thoughts? Are you participating? Is that something you'd refer a patient for?
Yeah, we're not participating right now, but I think it's a great trial just to understand the lay of the land. I think, there's less enthusiasm for targeted therapies, I think, in the neoadjuvant space based on some early trials, but I think it's probably the future. And whether it's combination with chemotherapy, we'll see when Neoadura and other trials read out soon. I think just knowing this stuff beforehand, whether we act on it or not, is going to be really important, particularly as we're juggling the idea of neoadjuvant chemo and immunotherapy. What do you think? You're a more sophisticated guy than I. What's your take on all this?
I agree. I'm a bit more sophisticated than you, but I can't operate for the life of me. So we both need to know our roles in this world. If you think about it, I agree with you. I think targeted therapy in the neoadjuvant setting is largely not as effective as we'd hoped. Neoadjuvant immunotherapy, extremely successful. There is an ongoing neoadjuvant sort of paradigm, the Nordica trials, where we're matching patients to specific targeted therapies in the space. And we look forward to seeing those results. If you have those patients in your practice, please enroll them at local sites so that we can understand this very important question. But to your point, Brendan, I agree. I think the adjuvant setting really is the setting where we've seen more durable, more long-term results.
All right, so Josh, big picture, it's easy, right? But tell me about the different ends of the spectrum. Stage one, do they need all this extra therapy? There was stage one, stage two, node negative patients. But then tell me about stage three. If they have N2 disease at presentation, should we just wait and give them adjuvant? What do you think about both those? Obviously for Adura and for Alina.
That's an impressively deep question for a thoracic surgeon. Brendan, I'm highly impressed here. So as you know, stage 3 patients have a high risk of recurrence, upwards of 75% 5-year recurrence rate. So I think there it's a no-brainer, right? And we know that unresectable patients, 3B and 3C, we don't even generally recommend surgery in all patients, more thinking of concurrent chemo-RT. But what about the other end of the spectrum? Let's go to that stage 1A patient, right? 1A3, let's say, tumor less than, 3 centimeters? Check me on that, Brendan, right? So if you think about a patient with a 1A3 lung cancer, their rate of recurrence is probably 10, maybe 15%, depending on what literature you read. Sure, if you didn't have an adequate mediastinal lymphadenectomy or, had the wrong surgery or there's high-risk features, maybe we have a discussion about adjuvant therapy. But generally, in those patients with early-stage disease, I'm not willing to give them this toxicity, the side effects of chemo, let alone the additional side effects of the TKI. So I have that discussion with patients, but generally, I really, really give that recommendation to my stage 2 and 3 patients. What are your thoughts, or you just step out of the way, stay in your lane?
No, thinking about it all the time. High risk stage 1. I've been, the recurrence rates were just so high in these patients in the control arm that I think that we need to offer them adjuvant therapy.
Yeah. So, interesting, different places, different practice, but, I'm happy that you're talking about this with your patients.
Yeah, I'm going to hit you with another.
Go.
Yeah, so Josh, you sort of dismissively said that stage 3 is a no-brainer, like surgeons don't really think about this. But the question really that I wanted to ask you is, what should we do though with the clinical stage 3, right? These were patients who went to the OR with stage 3, but say we have a clinical N2 stage 3. Should surgeons really take those patients to the operating room and then count on you guys to clean it up? Or should we be thinking about some sort of neoadjuvant strategy? Should they get chemo up front? Should they get chemo-targeted therapy up front? What do you think?
Yeah, it's a great question. Thinking about N2 disease is relatively tricky. I mean, sometimes we have whole tumor boards where we run through a case, fist fights and roll, and it's sort of the debacle from there.
That's just between the surgeons.
Yeah, the surgeon has to tell us whether the patient is resectable or not. I'm a major believer in if a patient is resectable up front, patient should get neoadjuvant therapy and then be resected. If the patient is not resectable up front, I would not, depend on neoadjuvant therapy to make that patient resectable. Using immunotherapy, using targeted therapy, I think we really need to be honest with ourselves and follow the way these studies were designed. So, we often get surprised of upstaged, 3B patients or even 3C patients who are post-resection. And boy, those are really tough discussions because we rob the patient of their neoadjuvant opportunity. Your thoughts?
Yeah, it's interesting. I mean, for EGFR patients, they have bulky sort of N2 disease or N2 disease. I'll give them the chemo up front and then ask for the osimertinib afterwards. And I think they still get the chemo and the osialakadura. It's a little harder, I think, for ALK patients. I haven't seen as many, but if you had a stage 3 clinical, I still might give them chemo neoadjuvant and then give them alectinib afterwards. I'd hate to omit the chemo there, and I kind of like the idea of getting something before surgery, even if resectable.
What about chemo radiation followed by a TKI? I mean, as per the LAURA protocol for, stage 3BC, EGFR rearranged, do you think the surgeon can do better than our radiation oncologist here? I think you have a Twitter feed on that.
What is this chemoradiation you mentioned? I've not heard of it. No, I think chemoradiation is great. And I think we're learning, though, too, right, that TKIs work the same here, right? Give them in the adjuvant setting for EGFR-positive patients with stage 3, for ALK-positive patients with stage 3, unresectable stage 3. And particularly, I think that's a great strategy, and it's going to be the way forward in the future.
We blew that one out of the water time-wise, but what an important discussion. And Brennan, thank you for having me, and thank you for this great discussion today.
No, always a pleasure to catch up with you and go back and forth. Really fun.